these questions are going to deal with PTH-dependent syndromes. So parathyroid adenoma, hyperplasia. Remember we said MEN was the 3 Ps, so people with that have 3 or 4 gland hyperplasia and need more extensive surgery. Bone disease, there's a lot of different bone disease. I think you see a ton of osteoporosis and may already know how to work that up. There's usually 1 or 2 questions about osteomalacia and Paget. And vitamin D is not very exciting. It's typically going to be the nursing home patient who is a little bit weak, can't get up from their chair. Their calcium is 8.5, their phosphorus is 2.5. They're never in the sunlight, and you just give them vitamin D. They're going to, gastric bypass patients, any shortcut patients, vitamin D deficiency may be asked. So this is a 72-year-old woman with mid-thoracic back pain. She's not smoking, but she doesn't get a whole lot of calcium. She has kyphosis, she has pain, and she has fractures on her x-rays at several different spots. Normal calcium, normal phosphorus, normal alkaline phosphatase. So all her lab studies are normal, and these are her bone density scores. Minus 1.9, minus 2.1, okay? So what does she have? What's the most likely diagnosis? And these are your choices. Even without the choices, what does she have? Yeah, she has osteoporosis. She has fragility fractures. It doesn't mean she has garden variety senile osteoporosis, which is a horrible term. It's now postmenopausal osteoporosis. So that means we don't really know. She just has weak bones. Maybe she never acquired peak bone mass. Maybe she just has bad genetics. That's 90% of all osteoporosis. 10% is secondary because they smoke or take antiepileptics or whatnot. But it's all called osteoporosis. So none of you think that she has osteopenia because she has T-scores of minus 1.9 and minus 2.1. Yeah, she has fractures, right? So it's like saying someone with a normal LDL doesn't have coronary disease after they've had their MI. So LDL of 101 doesn't define coronary disease. Your event defines coronary disease. So osteoporosis is just weak bone, and bone density is about 50% of what makes weak bone. The rest of it is genetics and bad luck and everything else. So if you have not had fractures, then you do have to depend on those T-scores. So this woman would have osteopenia if she had never had a fracture. But once you prove that you have a fragility fracture, which means fracturing spine, hip, or wrist with less than standing from falling position. So if I fall down 3 flights of stairs, I will obviously fracture something, but there's only so much stronger bone can be. But if you fall from a standing position or less and fracture one of these things, that's osteoporosis. Okay. Good. So 51-year-old man on routine physical exam, has no interesting history. He's running, he's exercising, he's not doing anything bad. His calcium's 11, his PTH is 120, and remember 65 or 70 is high. His calcium excretion is normal, so over 300 or 400 is high, under 100 is low. His DEXA scan looks great everywhere except at the distal third of the forearm, so that's kind of what goes along with primary hyperparathyroidism affects cortical bone more than trabecular bone, and so this is all cortical bone, this is trabecular bone. So they tend to have, so if you're worried about osteoporosis and that's something you're trying to work them up for to decide if they should go for parathyroid surgery or not, you do need to add that third site on your bone density scan. So what should we do for this gentleman? His calcium's not that high, but he clearly has primary hyperparathyroidism. Right? Give him some more calcium and vitamin D, help protect his bones because he's got a minus 2.5. Send him to surgery. What do you think? Surgery? Yeah, I think surgery is the right answer too. And even if you didn't know, look, B and E is like the same thing, so just take that off. So if the person didn't want to go to surgery, or if they had a T-score of 0.99 everywhere, I guess you could say, well, why don't we just watch him or treat his bone and prevent, because if you give bisphosphonate, you will protect the bone even if they have primary hyperparathyroidism. So if their kidneys are fine, they're not having kidney stones, their calcium is 10.8, they're a poor surgical candidate, but you're worried about their bones, alendronate works, it works. But this guy is young, under 50 is considered a criteria for going to surgery just because there's years and years of parathyroid disease to come. Osteoporosis is considered criteria for surgery, kidney stones, high creatinine, and hypercalciuria. So those are the reasons where even if the person doesn't want to go to surgery, you really ought to consider it. Young people are people with evidence of end organ issues. So a 28-year-old woman, also with the same calcium 11, her PTH is 40, so So remember, normal is 10 to 65, so just think about that. She's healthy, she feels great, but she has a family history of mom, maternal grandfather, who all had high calcium and high parathyroid and underwent surgery, but stayed mildly hypercalcemic. So what do you think she might have? There's only two things under PTH-dependent hypercalcemia. Everything is PTH independent. So your myelomas and your antacid abuse, there's a super long list of PTH independent. But PTH dependent hypercalcemia is just parathyroid adenoma hyperplasia and one more thing. I know you guys have heard of it. It's familial, it's the first thing in the acronym. Have you heard of FHH? Okay, this is really important. So it's familial hypocalciuric hypercalciuria. So if it's PTH dependent, it's almost always just going to be an adenoma or hyperplasia. But there are some people who have FHH, and they'll give you the family history if they do. So don't think this is MEN, because remember in MEN, if they underwent surgery, they should do better, and they should throw in like another tumor type or two. They shouldn't just give you parathyroid tumors. So FHH is just a mutation in the calcium sensing receptor on the parathyroid gland. So your calcium could be 9 and 10, but your parathyroid doesn't know it, so it keeps secreting lots of PTH trying to get the calcium up. So it just requires a higher set point. Once your calcium gets to 10.5 or 11 or so, the gland realizes there's enough calcium around and calms down. So classic teaching is that these people remain asymptomatic, they don't have end organ damage. Your main job as the internist or endocrinologist is to keep them away from the surgeon, because they will get surgery and still have hypercalcemia because they still have parathyroid glands. And the way to diagnose it is what? What's one of these things down here? C, yeah. So if the urine calcium to creatinine clearance ratio is less than 0.01, or if your 24-hour urine calcium is less than 100, you should really think about it. This is really, in real life, it's a hard thing to do because so many people have low calcium diets. There's a lot of overlap. But if they have a family history, and a lot of people with PTHs that can't get fixed, that's FHH. 65-year-old man with hypercalcemia, kidney disease, and a lot of parathyroid hormone, 1,500. He's got classic kidney bone disease, osteitis, fibrosis cystica, which are these brown tumors, which are really ugly. He's got four-gland hyperplasia. So he's your classic kidney patient who had initially hypocalcemia and hyperphosphatemia, so his PTH appropriately went up, and he had secondary hyperparathyroidism. And over many, many years, it became autonomous, and so it's now tertiary hyperparathyroidism. It's just, you can give him all the calcium binders you want or phos binders, and it's not going to help. So what should we do for him? I'm going to guess no one's going to say B or C, because his creatinine's too high for that anyway. Your creatinine clearance has to be over 30 to 35 to get a bisphosphonate. Calcitonin just is not really good for anything. So parathyroidectomy or cinecalcet? Stop. I mean, honestly, probably neither is wrong, but the answer here is cinecalcet, since it is now on the market and is approved for secondary hyperparathyroidism and tertiary and parathyroid cancer. We're supposed to try it before we go to surgery. So cinecalcet, the brand name is Sensipar. It's a calcinometic, so it tricks the gland into thinking there's lots and lots of calcium around, so that it will stop making so much PTH. Okay. And then if that doesn't work, then parathyroidectomy. So I don't know if we have time to do thyroid. I'll try. So just remember, thyroid gland works primarily by making a whole bunch of T4, not very much T3, but it all gets converted to T3 because that's the only active form of the hormone that works inside cells, and then it works at many different target tissues. I won't go over this, but basically you need to know if the thyroid levels are high or low. Odd TFTs, I think you guys will have a lot of knowledge about. This is a guy on interferon alpha who has hyperthyroidism, and he has a low iodine uptake. So what does he have? Interferon-associated grade thyroiditis. Okay, so if you have a low uptake on thyroid scan, it means you are just dumping tons of thyroid hormone. You're not manufacturing it because you're not taking up iodine. So if someone has an interferon-associated thyroiditis, methimazole is not going to work because they're not making thyroid hormone. You can't ablate them because they're not taking up iodine. Prednisone is used for other types of thyroiditis, like subacute, inflammatory. Basically, you don't do anything. You take them off interferon and you just control their symptoms. I guess you could do surgery if it was that bad, but I've never heard of that coming to that. So they stop the interferon, you would just give them atenolol. Okay, and that's the treatment for most of these things. This is a thyroid nodule. So an incidental 2-centimeter thyroid nodule. What's the first step in evaluation? Do you want to biopsy it? Oh, the first step is at 1.8 TSH. So you check your TSH first. And then would you do a scan or a biopsy? I guess that's my question. Yeah, do a biopsy first, because a scan is useful if the TSH is really low. Then it might be a hyperfunctioning lesion. So if your TSH is 0, don't biopsy it. Send them for a scan first. If it's hyperfunctioning, you don't want to biopsy it. Hyperfunctioning lesions are almost never cancerous. And if you do biopsy it, a lot of times you get a funny in-between reading called folliculoneoplasia, and it confuses everyone. So very few people need a scan first for a nodule, but if they're hyperthyroid, they do. If they're euthyroid or hypothyroid even, just biopsy it if it's over a centimeter. And this is a thyrotoxic gentleman, oh, this is a good one, who's on all these drugs. He's hyperthyroid. We don't really care why he is. They just want to know, what do you have to do to the therapeutic regimen while he's thyrotoxic? So how does being hyperthyroid affect your medication? So intuitively, you would think it just turns your medications over faster, and it does. That's the answer for almost everything. So you just have to increase the dose of what you're on. But there's one drug in particular where that's not true. Okay. So warfarin doesn't really affect the metabolism of warfarin so much as it does the vitamin K-dependent clotting factors. So it turns your clotting factors over more quickly. So you actually have to decrease your warfarin dose. Everything else you have to increase if they're hyperthyroid. There's a couple of these on there. So that's a fairly easy one to remember, I think. And so a pregnant woman who is hypothyroid, she's on levothyroxine before she gets pregnant. She's got a lovely TSH. And then she wants to know, what's the most appropriate approach? So are you going to tell her you're fine, you're going to stay on 100 your whole pregnancy? Are you going to increase her dose by a little or a little more? Or switch her to Cytomel or natural thyroid preparation? So in pregnancy, do your thyroid hormone needs to stay the same or go up? Go up, yes. So they go up for a lot of reasons. The main is that you make a lot of estrogen. Estrogen increases production of thyroid binding globulin, so you're binding up all your thyroid hormone. If you have a normal thyroid, it's no big deal. Most women double their thyroid hormone production in pregnancy. At 10 weeks of pregnancy, most of us have a TSH that's a lot lower than our starting TSH because we're doing what we're supposed to, and HCG stimulates the normal thyroid as well. So that's normal thyroid physiology, and this woman has no thyroid that's functioning, so you have to mimic physiology for her. So not everyone has to go up, but in general, the answer is C, about 30 to 50%. So if you guess, I tell this woman you'll probably be on 125 to 150 by the end of pregnancy. Sometimes we're right, sometimes we're wrong. And this is not that common. So an old woman with a big, expanding thyroid mass that's causing suppressive symptoms. It's a 5-centimeter mass. She's stridorous. This is what she has on FNA, numerous lymphocytes. So if you have big, expanding thyroid mass, there's only two things it's going to be, anaplastic or lymphoma. Okay, anaplastic is spindle cells on path, and lymphoma is lymphocytes on path. So in real life, this is a really hard diagnosis to make because bad Hashis, like really bad hypothyroidism that's been untreated TSHs, maybe it's not high yet, but the person can have a very big goiter. You've seen these ladies with big, huge multinodular goiters, and if you biopsy their gland randomly, they're going to have lymphocytes because it's Hashimoto's. Then you have to end up doing flow cytometry to figure out if it's cancerous lymphocytes or not. But if it's lymphoma, then it can respond to the same thing other lymphomas respond to, chemotherapy, maybe radiation. It's not a surgical disease like other thyroid cancers. So I don't really deal with this at all. I just make the diagnosis maybe once in exactly 10 years, and I send them to somebody else. But anaplastic is other things that I'll present like this. All right, I think we've done enough. Okay, so if you want the diabetes part, you can look at it.
Okay, great.